Okay, today I'm going to talk in adult practice, so OTH 827, about home health care, and then we will transition to end of life care. So, in home health care, to get a good idea of it, just take a look at your own living space. Um, and imagine if you were in a wheelchair, had balance issues, were really fatigued and had endurance issues. And take a look at your home and think what challenges would exist based on those conditions. So be sure you look at, how you get in and out of your home. Some of you might need to go up and down a lot of stairs. Um, some of you may live in big apartment complexes, right, and have to navigate elevators and walk a long way in a hallway, um, up and down flights of stairs, all of those kinds of things. Think about getting into your bathroom, and just the whole environment and setup of the bathroom itself. And if you had a wheelchair, you weren't able to walk very well or had balance issues, what might be some of those challenges? And same thing in your bedroom and kitchen. So take a moment and look at your environment in those ways through the lens of somebody with some kind of physical disability. So as you're looking at those things, and this is how OTs always think, right? Whenever we walk into somebody's home, is where are the issues, right? Are there parts of the environment we'd want to modify or accommodate? And then what are those suggestions? So we're always trying to problem solve with our clients. What would make things a little bit easier? What would make things safer? So maybe you can think about your role as an OT student, right? In just, is there anything in your environment that you could shift to make your role as a student any easier? So orienting ourselves to home health care as an OT, many of your clients may have an experience gradual decline, right? Typically in home health care, it's that older adult population. They may not want to go to a skilled nursing facility. They may have been hospitalized for some kind of an injury, such as a fall, hip fracture, or shoulder fracture. Or they may just gradually be becoming more debilitated, having poor endurance, and as a result, not taking care of themselves, not bathing for long periods of time, being too tired to cook healthy, nutritious meals, unable to go to the grocery store. And so there could be this very gradual decline, whereas others have more of that abrupt disruption, like maybe a hospitalization or something like that, in which, again, it comes to terms of additional hospitalization. Are we transitioning to home? Are we going to skilled nursing? And sometimes home health care is a good option for those who might have the potential to stay at home, but just need additional services for a while. So way back when home health care started, or the home care model started, way back in Florence Nightingale, right, doing home visits. And you probably can think of some older movies where doctors did the visits, right? Everybody came to their home for their home visits to provide healthcare. And so in the late 1800s, that model sort of expanded into the United States. And it's definitely shifted over time. And that's where we're still seeing home health care, and healthcare being provided in people's homes. Related legislation that's perhaps more current is people 65 and older, or people under 65 with certain disabilities likely will qualify for some type of Medicare. Medicare Part A, Medicare Part B, Part C. Just sort of depends on their situation, their policies, those sorts of things. And Medicare will pay for home health care services if they qualify for those services. When we look at the impact legislation, so Improving Medicare Post-Acute Care Transformation Act, really this is trying to hold hospitals more accountable to making appropriate discharge plans. This act is trying to improve healthy communities. It's trying to make healthcare more affordable or looking at the cost. And so when you think of people being discharged soon, back in the day, acute care, you'd be in acute care for 2 days, the doctor would send you home, right? And then there was a huge chance that you weren't ready to be discharged yet, and then you would fall and have to call the ambulance, and they would readmit you to the hospital. So the number of readmission rates of our patients were really increasing. And so this act really looked at how can we better manage that? How can we try and reduce readmissions into hospitals? And maybe we need to look at the quality of programs required or those discharge plans and see what we can do. So they really started looking at incidents of falls. They really started looking at adding PT, OT services, speech therapy services to look at more of those functional areas of a person's life. And again, looking more at that preventative aspect. Is there anything we can do to prevent readmissions? Home health agencies are their own agencies. A lot of times when I've seen home health care or the home health I contracted with, we were housed under a hospital, right? So we were housed under a hospital, but we had a home health department. And so you might see private home health care agencies. You might see some home health agencies that are covered under long-term care or covered under hospitals, right? But home health has their own policies and they provide nursing and therapeutic, skilled therapeutic services in the home. Medicare is the single largest payer source or reimbursers for home health. So I mentioned earlier that there is some basic coverage or criteria to qualify for home health care, and you must have all of these different requirements. So the biggest one is you must be confined to your home. I'll talk a little bit more about that definition of homebound, but to qualify for skilled home healthcare services, right? A patient can't just easily hop in their vehicle and drive to access those services. So there should be something that's confining them to their home. They need to be under the care of a physician. So all of their healthcare services that they're receiving under home healthcare, again, is guided by a physician. All of the plans that they receive, so this could be the nursing care plan, this could be the PT, OT, speech therapy care plan, should be reviewed, and typically they're signed off and approved by the overseeing physician. They must need some kind of skilled nursing care on an intermittent basis. So I'm thinking of skilled nursing. There's maybe some kind of medication that they can't just administer themselves, or they can't be taught to administer themselves. So a lot of times some patients would be discharged home with skilled nursing because skilled nursing would have to go in and do some IV antibiotics for a certain length of time, okay? Or some specific kinds of medications where the patient, again, was homebound. They couldn't just come into the clinic and get those medications and come home. Sometimes PT or speech, they can open up and qualify a patient for home health coverage. once those disciplines are in place, they can make a referral for OT, and then OT can get involved. Typically, I'll talk about this a little later, but perhaps they have a continuation or a continuing need for OT. And so maybe we're seeing somebody in a transitional care unit, we're recommending OT to continue home health care. And if they qualify under skilled nursing and skilled PT or speech, then OT should be able to continue as well. So when we're looking at homebound, again, I've seen where this is a little bit gray as far as what this means. When you think of confined to the home, I think of can never leave the home. I think some home health agencies interpret that as just making it hard to leave the home. So, do they need a caregiver to lift them and carry them downstairs or upstairs? Well, that would be considered homebound because it takes that extra person. It's really difficult and challenging for that person to leave the home, right? As we know, with community mobility options and those sorts of things, if somebody just doesn't have their own car or can't drive, that may not necessarily mean that they're homebound, right? Because they should have accessibility to community mobility, transportation, those sorts of things. Typically, when a person lives in an assisted living facility already, that has skilled care or has a continuum of care there, maybe they're attached to a skilled nursing home, they will not qualify for home health care, right? Because they already have that continuity of care on site. So when we look at homebound, the patient must either, because of illness or injury, need aid of a supportive device, right, to leave their residence or special transportation, right? So perhaps there's a specialized transportation that they need with like a wheelchair lift, something along those lines. They have a condition where leaving his or her home is medically contraindicated. So I have had some home health clients that were contraindicated to leave their home just because of risk of or difficulty breathing, right? And what happens if they run out of oxygen? They were so dependent on oxygen. And so being that dependent on oxygen, the physician was able to say, you know what? We do not recommend that they leave their home. Again, a little gray area when you're looking at hard to leave a home. And that home health agency is typically the one that makes that determination on, is it hard enough for them to leave their home, right? Just because they have a cane, wheelchair, walker, doesn't necessarily mean they're homebound, right? Or they're confined to their home. There's many people in our community that get around in those areas. I already talked about where leaving their home could be medically contraindicated. And so if a person is confined to their home, they meet those conditions, then they must also exist in normal inability to leave their home, and it must be considered a considerable taxing effort. Okay, so again, how they make that decision sometimes comes down to the home health agency. So for OT, when we're working in home health, we need to know what's going on. We need to know the regulatory guidelines, right? So are people being admitted? Typically, it's not OTs that are running the home health agency. Typically it's a nurse, and they understand the regulatory guidelines. However, there are certain policies and procedures of home health agencies that are really important, such as who's responsible for some of the documentation, who's responsible for scheduling services, who's responsible, like what happens if nursing wants to discharge but OT wants to continue. How does that look? What are those policies and procedures within that agency? What is the legislation and standards? So Section GG is coming out, or is supposed to have been out, right? And we're supposed to be doing Section GG charting in home health agencies. However, home health agencies also have their own comprehensive assessment that they just don't want to let go of, right? And it's called the OASIS. Not sitting on a beach somewhere under palm trees, but it's something, it's just how they name what they name their comprehensive, interdisciplinary, multidisciplinary assessment, where they're gathering data on their patient and tracking progress over time. Obviously, working in home health care, there's HIPAA considerations. Sometimes it's a little bit tricky, I think, when you're driving to people's homes and you're going from one home to the next to the next. How are we following protection of records and information? If we have concerns and we're picking up the phone and we're calling, are we compliant with, are we communicating with the appropriate people with the appropriate types of information? And so your home health agency is going to have a lot of strict rules on following your HIPAA compliance. And communication issues in home health can be very challenging. My experience in home health care, again, I was contracted in, so I wasn't a direct employee of the home health agency. I was an outpatient therapist that was contracted in this home health agency. So I had to make sure I was communicating with the home health agency. So the director of home health, she would often give me, she would help me schedule. I would tell her my availability. She would work on scheduling for me. She would give me patient information. She would give me the address, any referral source, any information about the referral, diagnoses, those kinds of things. So then I'd get an idea of what our role, or what my role as an OT would be. Typically, again, there's an assigned nurse, there may be an assigned PT, there may be an assigned OT, an assigned speech therapist, there may be an assigned nurse's aide. It really depends on what that agency offers. And so, of course, when we go in there and we're looking at, okay, what is it that we're working on? Does that jive with some of the other disciplines that are going in providing services? So, a good example might be, as OTs, we're looking at increasing somebody's safety and independence with maybe an activity of daily living. So after a hip fracture, they're discharged home, right? They have a bath chair, a walk-in shower tub combo. They have grab bar placements that were all recommended. They practiced with those things in the hospital before discharge. The family got those devices into their home. And so it might be one of our roles as OTs to increase their safety and independence using those devices, right? And so we're not going to be there with them every time they want to bathe, right? And they may have qualified for a nurse's aide to come in and do some of the self-cares for them or with them. And so it's really important that we communicate with that nurse's aide on how is that person, how is that patient using that equipment. We would probably have to train that aide in helping that patient use that equipment, make sure they know how to use that equipment, since they'll be the ones that are using it, right? So that interprofessional collaboration becomes extremely important. You'll also see some overlap with maybe treatment ideas. So as OTs, it might be in our scope of practice to help with medication management, right? However, that might be the skilled thing that keeps them under skilled nursing care, where nurses come in, they administer the medications, they set them up with a medication scheduler, right, to help with reminders, those kinds of things. So it's helpful since we're going into the home and we know that's what nursing is working on. Is there anything we can do to sort of look, monitor, make sure that that's happening? And if we see red flags, can we then communicate with the appropriate discipline and update them on progress? So it's not unlikely that we would have case conferences, right, where everybody that's on my home health caseload, I'm sitting down with some of the charge nurse or the nurse in charge, the agency director, maybe the physical therapist, speech therapist, and we're talking about what it is that we're working on, what it is that we're seeing in the home with that patient, how things are going, what our plan of care is. Because I was a contract person and I wasn't home health care full time, a lot of times I'd have to pick up the telephone and probably ask to talk to the director, or hey, who's the nurse that's working with this particular home health patient? I need to talk to them, right? And so picking up a telephone, leaving voicemails. Home health nurses are really hard to get a hold of because that's what they're doing full time, right? They're going to patients' homes and they're likely not going to answer their phone when they're working with a patient. Okay, so it's a little bit different. Also, written communication is really important, and so the physician really does take a look at our documentation, and they're constantly looking at and following. They should be following that patient's progress. I've talked about the OASIS already, and this was back in 1999. This was the go-to form for home health agencies. And basically, it's their way of collecting comprehensive data about everything you would want to know about the patient. And really, it should be a collaborative effort where nursing is going in there. They're assessing perhaps skin checks, skin integrity. They're looking at medications, skilled medications that they're on, bathroom toileting, bathroom habits, those kinds of things. I mean, I'm not doing it justice, everything that nursing does. OT should be looking at, what's their skill level with getting themselves dressed, with cooking, cleaning, those kinds of things. PT would be looking at, ambulation, functional transfers within their home. This could certainly be looking at functional transfers too. Speech might be looking at swallowing, might be looking at cognition. Again, OT can be doing some of that too, looking at functional cognition. So, it really is helpful. It's a super comprehensive report. And again, it's meant to collect data upon admission. What is that patient's level of care at admission time? And then once they become discharged or once they're on home health care for so long, we need updates to that OASIS, right? And sometimes when maybe nursing has said, okay, they no longer need their skilled medications, right? And PT has discharged, saying, no, they're functional in their home with their functional transfers. And OT, we're still working on maybe some cooking safely, right? We're still working on bill paying. Maybe we're working on some of those higher level IADLs. Well, then it comes to us, since we're the last discipline on caseload, for us to complete that discharge OASIS. So then we have to look at, oh my goodness, we have to collect data on medications, we have to collect data on functional transfers, on swallowing, on absolutely everything. And that can be daunting and sometimes frustrating because it is so time consuming. But, in the perfect world, we'd be picking up the phone and saying, hey, can we do this together, right? Data that's gathered and that progress you show with that data, hopefully, will help with quality initiatives, right? It should measure overall performance of your client and help guide those reimbursement categories for home health services. So again, it's home health is something that's constantly changing. It's important to review the most current policies and updates with your healthcare agency or home health agency. If nursing and rehab is selected, in my experience, nursing is generally the one that goes in and opens the case, maybe starting the OASIS paperwork. If it's only rehab, PT and speech could open the case. Legislation has not allowed OT to open the new cases, which I think is just ridiculous with everything, how comprehensive we are, what importance we know that natural environment is to performance, and everything that's in our scope of practice. I think it's just ridiculous. I say it may be changing. With COVID, there was some and healthcare shortages, people wanting more home health care because they wanted people to stay home and not go to some of the facilities just because of COVID. They did make an exception where OT could open up home health agency cases due to short healthcare workers and the demand placed on home health care. Since then, AOTA has said, hey, we want this to be permanent. And to be honest, in searching where we're at with that, I haven't really found exactly where we're at with that right now. If that's been approved, or if it's still in limbo, if it's still in legislation. So again, more to be changing on that. Typically, when somebody's referred to home health, that initial comprehensive assessment needs to be done within 48 hours of referral or 48 hours once they're discharged home. So really, when somebody is home with home health care, we have to get in there immediately and start that evaluation. We can't just sit on it. Documentation in home health care, we are continually communicating, right? There were written communication logs that we had to fill out. We always want to document how effective our services are or were, the client's response to treatment, ongoing assessment, meaning, what are our changes that are happening with our plan of care? And if there are any essential elements to reimbursement, so if there's any issues that come up, I'm thinking like skin integrity issues or decline in status or any of those kinds of concerns, right? Or they're requiring more assistance or something's not being done, that could be an essential element for reimbursement or qualifying for more types of services. So it's always important to communicate those. Now, I mentioned the OASIS is sort of that multidisciplinary, sometimes when the nurses are opening up a case, it wouldn't be uncommon for them to call me up if they knew I did my initial eval and say, help me out. What was their level of assistance with dressing? What was their level of assistance with functional transfers, toileting, bathing? Right? It wouldn't be uncommon for them because those are baseline things that I would naturally assess as an OT, right? In their home environment. So sometimes, again, I've been part of filling in the OASIS documentation. Sometimes, more commonly than not, it's been the nurse that calls me on the phone saying, hey, I need your help filling this out to get that baseline information. So it's not like doing the OASIS is our baseline information. It's baseline information important for the entire home health agency. But if I'm an OT under that agency, I'm going to be looking at how is the patient dressing? How are they getting in and out of bed? How are they taking themselves to the bathroom? How are they doing hygiene? How are they bathing? How are they cooking? How are they cleaning? How are they doing bills? Okay, so I'm really going to be focusing on those areas of occupation um, within that patient's home. That would be this discipline specific piece, right? That's part of OT. Um, it could be also physical therapy, looking at the physical aspect. What is the strength? Those kinds of things. We may be using objective tests and measurements as much as possible, right? So it wouldn't be uncommon for us to do some standardized assessments. One of the common ones that I used to administer in home health was the Coleman evaluation of living skills, just again for that objective data. And it was just, something that we had that also measured that mental or cognitive piece associated with it. In home healthcare, what's super, super exciting, and I would say the best part about it is you get to actually work with the client in their natural, realistic environment. They're typically relieved because they're at home. They're typically excited because that's where they wanted to be, was at home. And it's because of you where you're helping them be safe and effective in the environment where they want to be. And so that can be really, really exciting for the client and make you as a therapist feel like you're really making a difference. So again, we would do our interventions right there with our patients too, right in their environment. So we might be doing things with falls, overall safety, a lot of preventative types of things. Again, we'd be looking at ADL retraining, IADL retraining to encourage as much independence as possible. We might be doing some environmental modifications right then and there. Or we might be making recommendations to a power of attorney or to family members, right, and getting them on board, or nursing, right, some kind of follow through to enforce some of those environmental modifications we're requiring. Sometimes that can be tricky, right? I am not a handyman. And so if I think a patient really needs grab bars and they have a beautiful tile walk-in shower, I don't feel comfortable just drilling into tile, right? I could totally split it, it could shatter. I don't have the right tools or equipment to do so. So I might be recommending use of grab bars and grab bar placement, but also hiring a carpenter that knows how to do some of those modifications. Support care providers. So this might be looking at other community agencies. Maybe they hire a nurse assistant that's private pay. Like maybe they didn't qualify for one through home health, or maybe the home health agency doesn't have that, right? Or homemaker services, I think we used to call it. And so are there other things that we can recommend to help them be safe and independent in their home? Are there other community resources? I'm thinking of Meals on Wheels, right? So can they get one meal a day, 5 days a week? Like, would they qualify for that? And so it's helpful to know what's available in the community. And again, what's going to help them with safety and what's going to help them stay in their home. So that's just a very small tidbit on OT and home healthcare. Again, it can be really exciting and rewarding because we're working directly in that natural environment. It can also be challenging because there may be times when people shouldn't be at home. And I've walked into quite a few of those situations and scenarios that have been pretty scary. And really, really sad. So anyways, that's what I have on OT and home healthcare. And next, we're going to switch to end of life care. So I'm going to stop sharing. And I will pull that one up right away. So not a really exciting topic. It's kind of sad, to be honest with you, or it can be sad, and so I didn't put a lot of frills on this particular PowerPoint. I thought it applied well here with home health care. Our home health care agency that I contracted with also did end of life care, so it was home health and hospice, right? And so you might even see hospice as part of some home health care agency names. Um, and so when it's hospice, typically we're dealing with perhaps comfort measures, maybe the end of life is near, um, those sorts of things. So each year, more than 2.4 million people die in the United States. And by 2040, with our increase in population, it's likely going to be 4 million. I think we all know and all have dealt with people who have passed away. It touches everybody. We're dealing with grief, transitioning in life, family, or our roles change when we lose people that are near and dear to us. And it's unfortunately part of life, right? 10% die suddenly, maybe from a sudden stroke or maybe something traumatic that happened. Most require months or weeks of care while health steadily declines. When interviewed, 90% of Americans said that they would rather be cared for and stay at home and die in place. However, only 40% seem to be actually doing that. 1/3 die in hospitals, 1/4 die in long-term care facilities, and research shows that far too many die in pain. So when we're aging, as people age, it naturally, people become more aware that end of life is coming. They may feel loneliness, they may feel anxious about leaving other people behind. Some may have emotional distress. Some may observe their abilities decline over time. And may experience more frustration with their decline with just their basic activities of daily living. And we may see more bouts of depression and learned helplessness, and those kinds of things with that as well. The aging are more susceptible to deteriorating illnesses. They may feel a social stigma or feel marginalized. I think we all know that aging population typically requires more healthcare services. And I think because of the complexity of the aging individual, evidence shows that their assessments aren't sufficiently assessing all of those different complex issues. And a lot of things may go undertreated. End of life requires working their sense of self, coming to terms with what abilities they do have, coping with the end of life is near, and still creating meaning with what life they have left. When providing end-of-life care, it really requires a holistic understanding of the life cycle. I have worked with patients who are on hospice and patients who are end-of-life. And some of the best advice that was given to me was from an end-of-life or hospice nurse who shared that working with clients at their end of life is just as special and meaningful as it is working with somebody at the beginning of life. Because the end of life, the beginning of life, the middle of life, it's all life. And we all need care throughout that span of life. And so anyway, she just really brought an awareness to me that working with somebody when they're in their last stage of life um, is is really an honor, right? It's really a privilege to be there with somebody as they're getting ready to pass. Um, as OTs, we really help people with their daily occupations, and it in this type of situation, it might be helping that person hang on to what it is that they find meaning with. It might be helping them find meaning in something new. It might be helping the client with their family um, and maintaining what integrity um, that they have left. Um, so end of life care, sometimes known as terminal care, helps those with an advanced, progressive, incurable illness to live as well as possible until they do pass away. It really could include things such as pain management, um, psychological, spiritual, and just overall practical support. So those people in end of life care, I'm thinking of those with maybe incurable cancer. Um, those nurses are doing a lot of pain management, right? They're giving them a lot of heavy pain medications, so they're not in pain. I think as OTs, there are lots of things we have in our toolbox that aren't pharmacological, but that also are able to help with pain. Um, a lot of year two students right now we're doing holistic wellness plans and we're looking at spiritual needs, we're looking at psychological needs of patients. Um, that would very much be applicable to this kind of a setting. End of life care, typically you'll hear the terms hospice or palliative care. And so those are types of services that typically are provided when it's known somebody is at their end of life stage. So hospice and palliative care are comprehensive interdisciplinary approach, and they're both meeting the needs of not just the patient, but the patient and the families. We know that families are going to, with the loss of their loved one, have grief, loss. There's things that they're going to have to do to prepare for funerals, to prepare their next life stage moving forward without that person that meant something to them in their life. Hospice and palliative care are going to look at symptom control and optimizing quality of life. And as I mentioned, we really see dying as a natural process. So, it shouldn't necessarily be the focus on loss and sadness. It should really be seen as this is a natural process of life, and how can we make this the most comfortable for this person to go through because it's inevitable. So we have stress reducing suffering, patient family centered. This allows and facilitates care choices. So what's important to the family? The team includes physicians, nurses, nurse assistants, OTs, PTs, dietitians, probably going to have some kind of spiritual care, maybe with priests, pastors, social workers. So again, it's really interdisciplinary. And again, we're focusing on making that patient and family as comfortable as possible. There is a difference between hospice and palliative care. Hospice is caring for those perhaps with a life-limiting illness, right? So I'm thinking of terminal cancer, where they're no longer seeking curative treatment. Now, my grandmother was on hospice and she had She had terminal cancer, and she continued chemotherapy because that chemotherapy was keeping her cancer at bay, and providing her relief with her breathing, because the cancer was really aggressive in her lungs. And so by keeping on the chemotherapy, it really prevented breathing issues. Therefore, that chemotherapy did continue even though she was on hospice. To qualify for hospice, typically a physician has to provide a prognosis of 6 months or less to live. Families with hospice are typically, or the primary caregivers. There are residents that are in long-term care that do have hospice, and they do qualify for hospice care. Volunteers are a really important part of the team in hospice, so they may go in and they may do social one-on-one visits. They may do prayers. They may provide some reading materials, reminiscing, a lot of those different aspects for the patient. And hospice includes bereavement care as well. So once that person has passed, right, there's a care team in place that helps that family with bereavement as well, which is kind of nice. Palliative care is not limited to just end-of-life care. So a person may receive palliative care when undergoing curative treatments. And so palliative care is just those comfort care measures as well. And they can be offered throughout the continuum of illness. Palliative care promotes support for those treatment decisions with the patient and the family, by providing them with the tools they need to make those decisions as a family together. So a very subtle difference between palliative care, comfort care, and actual hospice care. When we look at quality of life, we're looking at the physical aspect, the psychological aspect, the social aspect, and the spiritual aspect. And so again, with hospice care, with palliative care, right, we really want to impact a person's quality of life. We have in our OT arsenal, we've heard quality of life a lot, right? We have measures for quality of life. When we look at physical, functional abilities, strength, sleep, pain, those kinds of things, I think OT has an important piece to the puzzle. We're not the only piece to the puzzle, right? But I think there are things that we can bring to the table. With psychological, cognitive, attention, depression, anxiety, leisure, okay, pain or distress, happiness. Again, OT has those pieces of the puzzle that we could use with this population. Social, okay, so dealing with appearance, affection, sexual function, roles, relationships, caregiver burden, financial burden, all of those kinds of things. I think OT in conjunction with social work, I think they're, again, pieces to the puzzle. And spiritual, right? There's a lot of, or not a lot, but there's some research preceptors in our curriculum that are really looking at the benefits that spirituality and addressing spirituality in OT has. And here is an area of practice where it's revered, right? And so spirituality can bring hope, can ease suffering, can give meaning to one's existence or one's experience that they're facing. And so it can be a real positive thing for coping. Cultural sensitivity, so around death and dying, right? We always should be looking at patients' cultural ethnic background, their view on spirituality, their view on death and dying. And so I've gotten some handouts from some nurses I've worked with in the past on common cultural and religious customs. And I want you to take a look at those cultural religious customs on death, dying, those rituals, and reflect on your own experiences and beliefs. What are our own rituals, right? When a family member passes, or somebody that we care about passes, what are some of the traditions and values that you hold dear? Now let's look at, okay, what if I'm working with somebody that's end of life care and they're of this other culture? Okay. Um, how does that feel to you? How does that look? Um, how do you think you'd be able to navigate those differences in order to help your client? So some of those were fascinating to me. So I've talked a little bit about OT's role, and OT does have a role, right? And I think of, again, being a contract person in OT in a home healthcare agency that also was hospice. I feel like when somebody was transitioned from skilled care to hospice, it was, okay, OTPT, go ahead and discharge because they're end of life, and they're not going to progress. And that's such a limited view of what OTs do, right? That's really looking at just the rehab approach, um, the biomechanical approach to therapy, and it's not looking at the holistic view of what we can do. So, implications for OT and what outcomes we could use to measure or to substantiate our services in the setting is helping a client prioritize resources and energy, right? So, energy conservation, right, is huge. Somebody is end of life. What can we do to help them prioritize what it is that they want to do versus what it is that they can let go? Okay. Teaching them compensatory strategies. Are there home modifications that they can do to make their life easier? Is there adaptive equipment, assistive technology that we can implement? Okay, working with somebody who is more palliative care because she has, I think, a diagnosis of MS and has just progressed. But she's finding the use of Alexa, really, really helpful in helping her remember certain things and helping her play preferential music to keep her upbeat. There's a lot of really cool things with assistive technology that she's doing just simply with that. We can do a lot with education. I'm talking about educating with transfers. Now, I'm not just sitting here talking to caregivers or talking to patients, but we could plan a training session with caregivers, right? How best to transfer their loved one from bed to sitting. Okay. Are there any types of seating devices that would support their change in position? Because as opposed to laying in bed versus sitting up, think of how much more we can engage in if we're sitting up in a position that's supported. We could educate on relaxation techniques. Okay. Mindfulness is a really popular one, especially if we're dealing with a lot of pain. Ergonomics. So again, that might be just overall body position to alleviate pain. Healthy lifestyle. We could do specific training to accomplish certain daily tasks. So is there a different way of doing bathing? Is there a different way of doing cooking? How are we going to help them manage fatigue? So again, that rehab approach, biomechanical approach is, strengthen, strengthen, strengthen. Well, if they have a debilitating disease, it's not necessarily about that. It's looking more at how can we adapt and compensate, because we're likely not going to restore, but we could adapt and compensate and still have meaning making for our patients. Are there other creative and symbolic outlets through engaging in meaningful activity? Okay, so instead of, right now I'm working with a lady who has some, I think she has Parkinson's, and she used to love to quilt and to sew. Um, Really important piece of her culture. Um, and so right now she has more, they look like coloring pages, but really she can take yarn and she can um, glue yarn and put it in the lines of this coloring device, and they're beautiful, beautiful pictures. But because she can't do needle and thread, she's also diabetic, so there's more neuropathy. She can do that. And so, are there other meaningful activities that are symbolic, that are creative to what it was that they were doing before? And I think as OTs, we have a really unique way of providing that similarity. Are there other opportunities for enjoyment? Okay. Are there other opportunities to establish routines? Or to establish part of their routines. Some tips. So, looking at holistically, are there ways where you can incorporate the client's favorite music in with their treatment sessions? Are there certain scents that are meaningful to the patient that they like? That help them remember positive times in their life. You can do things like audiobooks. So even if somebody is end of life and they're in bed and they're not able to sit upright and read, are there certain audiobooks of some types of stories? Family pictures, having family pictures around where they can see them and experience them. Use of family videos. There's so many different assistive technology things out there with, you can have like one picture frame and electronically it will play a slideshow of different family pictures. Again, the options are really endless. And then of course, any of our occupational therapy quality of life measures we could also use. And again, this is sort of an area of practice where you may not see a lot of OTs, but hopefully through this presentation, you see, wow, we really can have an impact here. It's a real honor to be able to impact and help these people in the last parts of their days. We have to collect data to show that we are a piece, that we are helpful, that we are a piece of the puzzle that can really impact these patients' lives for the better. And by doing so, we should have these outcome measures and measuring aspects of quality of life to prove, right, to prove that we can help. This was based on an article. They called it physiotherapy, which if you ever read articles from the UK, some other places in Europe, I think even sometimes Canada, if I remember right, they do use physiotherapy, and it's sometimes a combination between physical therapy. I really could see this as OT doing some of these as well. And so you're looking at pain relief, right? So addressing pain can be a big issue. Sometimes patients don't want to be on a lot of narcotics because it affects their stomach, it affects their cognition, right? It causes constipation, it causes a lot of other discomforts. And so maybe there are alternative ways of managing pain, such as heat, like hot packs, right? Heating pad, maybe a TENS unit, maybe massage, maybe chiropractic care, acupuncture, so many other alternative treatments, dry needling, okay? Obviously, we wouldn't do chiropractic care. We wouldn't do, I can't speak to that. I can't speak to acupuncture, but again, there are many, many, many other types of alternative treatments that people with chronic pain may seek out. Lymphedema. So sometimes I'm thinking end-of-life cancer patients, right? Lymphedema can be controversial, and it's usually contraindicated. because when you're moving and rerouting lymph fluid, it actually could spread cancer if that person is actively going through cancer. Okay. In my experience on my level 2 fieldworks, both of my fieldwork educators were lymphedema certified, and they both had been called in to hospice end of life care to provide lymphedema treatment because the person was experiencing a lot of pain because of a swollen extremity. Now it was contraindicated because they newly had a new diagnosis of cancer, lymphatic cancer, and so spreading the lymph could spread the cancer to other areas. So it was a really touchy conversation with the patient, with the family, with the physician, and knowing, is it worth the immediate pain relief to decrease the swelling of the arm, right, or of the leg, with the chances that it spreads cancer? And I can think of 2 cases where the patient, the family, the physician decided, you know what, the person's prognosis is less than 6 months. Let's make them as comfortable as possible now. The cancer is already spreading and has already spread throughout the body, so see what you can do. And that was really hard for my fieldwork educators. They really had to ethically think about that. It may have even went to some ethics boards. I think one of them brought it towards an ethics board. And so again, could be controversial. Physical activity. Okay, can we promote physical activity? Is it contraindicated? We know that if we increase physical activity, there's likelihood that it can decrease pain in some instances. It can also stay or maintain overall function. Therapeutic massage increases blood flow, could also increase endorphins, decrease pain. Passive range of motion, okay, that can keep muscles moving, joints moving, and further prevent pain from happening. Doing relaxation techniques, guided imagery, mindfulness, all of those kinds of things to promote relaxation also could help with pain. Stress could also help with managing anxiety, could also help with managing fatigue. I've alluded to this already, but are there different positioning techniques that we could recommend to alleviate pain, to increase engagement, whether that's social engagement with family, whether that's engagement in leisure activities, whether it's preventing joint deformity, whether it's preventing contractures, whether it's preventing issues with skin integrity, okay? And of course, advising and educating family, having sessions with family, I think would be very important. Helping family understand why you're doing what you're doing so that they can carry through with them when they're with their loved one as well. So I think hopefully with this presentation, you can understand that OT does have a place, or we have the potential to have a place, and it's up to us to sort of fill this gap and to educate others on our role. I'm going to stop sharing. There are other resources on Canvas that I think would be helpful for you to look at. Let's see if I can't. It's my home health one, the lymphedema one. So there were the handouts on sorry, I'm clicking and getting ahead of myself. On different rituals of death and dying. Again, not the most upbeat types of topics, but they really are quite interesting. There is a link also with home health. OT's role with OASIS is expanding This was August 3rd of 2021. And so, and there was a proposed rule for 2022. And so it was last updated February 2023. And so it's just a website to hopefully keep an eye on anything relating to home health, the Oasis. It seems like a really helpful site to kind of keep in the back of your mind if you're working in home health care. You'll also find things on AOTA relating to OT and home health care, because AOTA does a really nice job of advocating for us and trying to expand our services. So those would be some other resources if you do have a home health field work to certainly keep an eye on. All right, I'm going to get this posted. And if you have any questions, please let me know. Thank you.